After this, it's just right back down the strip to the Chinese buffet, where I'd go up at least 6 times, and then in the exact same parking lot, hit the Taco John's and get 5 bean burritos and 2 of those large orders of the potato olays. They're the little tater tot things that they serve in buckets. And then I'll eat that while driving and ordering from Domino's 4 large pizzas, an order of breadsticks, and 8 dipping sauces. And then get over to Domino's, pick that up, and then it's on to the last leg, the First Avenue Hy-Vee. On the way there, call China Walk and order 5 dinners of the tofu with veggies and garlic sauce and 4 egg rolls. Go to the Hy-Vee and purchase what should be a week's worth of groceries. And then pick up my order at China Walk. And then it's time to head home. Scope out the house, see how I can get all of this upstairs without anybody noticing. And then it's just binge and purge, in and out, until it's gone, until I am.
Bulimia nervosa is one type of eating disorder characterized by varying episodes of binge eating, followed by some compensatory actions. According to the DSM-5, the following criteria must be met for diagnosis. 1. The patient regularly binge eats, meaning that in a short, less than 2-hour time period, they eat more food than a normal person would be expected to eat under the same circumstances. Binge eating also occurs with feeling a loss of control. 2. Episodes of binge eating are then followed by some type of compensatory action, which may include fasting, vomiting, excessive exercise, and the use of diuretics or other medications in attempts to avoid gaining weight. 3. These patterns of binging and purging are practiced a minimum of 1 time a week for at least 3 months. 4. The person is not anorexic. And 5. The concern towards weight and body shape are taken to an abnormal extreme. Onset of symptoms typically begins in adolescence between the ages of 13 to 16 years old. The most common form of bulimia is a purging subtype constituting 94 to 96% of bulimics. Bulimia is also 90 to 95% prevalent in females, with middle to upper class Caucasians being the most susceptible. Additionally, near all bulimic patients are within 10% of the normal body mass index, or BMI. This is the most distinguishing factor differentiating anorexia and bulimia. Where bulimic patients are near average body weight, anorexic patients are significantly underweight. Having a concern with weight and image is not uncommon among young women. It is discerning the norm from the extreme that defines diagnosis. Diagnosis of bulimia nervosa is often more difficult than other disorders. Because people suffering from bulimia maintain a weight within 10% of the norm, they cannot easily be recognized by a significant weight loss. Often either a parent, friend, or physician will notice abnormalities and may perform a series of tests to confirm diagnosis. Tests include urine tests to detect changes in electrolytes, oral examinations to look for erosion in the teeth, and most importantly, questionnaires to help determine mental status. The most widely generalized model for the development of bulimia nervosa and other disorders stems from environmental factors and largely the sociocultural model. The 2 defining facets of this model are first the ideal thin body type for women, and second, the importance of appearance in both societal success and the female gender role. Within the past few decades, the characterization of a beautiful woman has focused more and more on having an ideal thin body. From the mid-20th century, there has been a drop in the weight-to-height ratio between models, actresses, and pageant contestants. Similarly, pageant winners, the most stereotypically beautiful women in society, have typically had lower hip, bust, and waist measurements than other contestants. The percentage of diet and exercise articles in magazines has simultaneously been on the rise. The pressure to have a thin, fit body has never been higher, and while it is common for most women to feel some sort of societal pressure to achieve this thin body type, bulimic women take this ideal to a dangerous extreme. The importance of appearance for both societal and career success additionally fuels its hyper-internalization of a thin ideal. In the workplace, more feminine and attractive women exhibited more social skills, were more mentally and academically healthy, were more dominant and self-assured, and had less social anxiety. Studies have shown that some sort of parental problems have been found in a majority of bulimia nervosa patients. The families of females with eating disorders are believed to perpetuate a hyper-consciousness of weight and appearance onto their children. A similar pressure from peers has been shown to influence the development of bulimia in women. Eating disorders have been stereotyped as a result of sociocultural pressures heavily prevalent in society. However, new science has begun to show otherwise. According to Bullock and researchers, studies have now shown that bulimia nervosa and several other categories of eating disorders are largely familial. In particular, the additive effects of genes are thought to be largely responsible for this dependence. Recent twin studies have shown that the inheritability of bulimia nervosa is approximately 54 to 83%. Further investigation suggests the presence of a gene that increases susceptibility to bulimia nervosa on chromosome 10p. There is additional evidence to suggest a higher correlation between bulimia nervosa patients and familial histories or childhood histories of obesity when compared to normal subjects. Kay, Gindel, and Strober also mentioned the role of serotonin 5-HT in both anorexia nervosa and bulimia nervosa. Studies have shown that variations in the 5-HT neurotransmitter receptor plays a role during manifestation of the disorder and into recovery. The importance of this receptor is growing in the scientific community and has been mentioned in several experiments, some which denoted 5-HT activation to be directly correlated to satiation. These same 5-HT pathways have also been noted in the control of mood, impulses, behavior, and obsession, which could lead insight into the causes of bulimia nervosa's comorbidity with other psychological disorders. Bulimia nervosa is highly comorbid with other types of neurological disorders. The occurrence rate of bulimia nervosa was found to be similar to the rates of other anxiety disorders, and approximately 2/3 of the subjects suffering from eating disorders also had at least one other lifelong anxiety disorder. One study showed that the onset of the comorbid disorder often occurs before the development of the eating disorder. This leads indications that the same psychological vulnerabilities that lead to anxiety disorders are the root cause of eating disorders as well. Other studies corroborated this effect. There was a significant difference in the level of exposure to putative risk factors between healthy patients and those with bulimia nervosa. It is likely that this exposure, in addition to exposure to risk factors that increase the risk of negative self-evaluation and dieting, increase the likelihood of developing bulimia specifically. Like all psychological disorders, bulimia nervosa stems from a multidimensional model combining environmental, psychological, and biological factors. Therefore, the severity and duration does not always have a clear and distinct course. Impairment in the central nervous system involving the response to the serotonin pathways are likely partially responsible for the maintenance and onset of the binging and purging habits of bulimia nervosa. Some recovered bulimic women reported binging an average of 28 to 40 times per week and purging between 33 to 43 times per week. Women using laxatives also reported use between 58 to 182 times per week. Unless treated, the Mayo Clinic emphasizes bulimia nervosa to be a severe chronic disorder. Effects of bulimia begin within months into consistent binging and purging habits. For example, most bulimics show indications of teeth erosion after approximately 6 months of purging activity. In one study, researchers found enamel erosion in 78% of subjects, in addition to dental caries, dental hypersensitivity, and parotid dysfunction in majority of subjects. The severity of erosion was directly correlated to the frequency and duration of purging activity that occurred. Unless treated, the Mayo Clinic emphasizes bulimia nervosa to be a severe chronic disorder. Effects of bulimia begin within months into consistent binging and purging behavior. In addition to teeth erosion, WebMD recognizes the possibility of several other effects of bulimic activity. Chalmey, Anderson, Shutter, and Whitehead also found the majority of patients suffering from bulimia nervosa simultaneously reported several gastrointestinal problems. These symptoms were seen to improve proportionally with treatment and a decrease in binging and purging activities. Even if the behaviors of bulimia subside, it is likely that the comorbid disorders will continue to need attention. Of the recovered bulimics, 68% are comorbid with lifetime depressive disorder, 25% with OCD, 11% with GAD, 32% with alcohol dependence, and 21% with other substance dependence. It is estimated that 30 to 60% of women with bulimia make a full recovery from the disorder. However, studies have shown bulimia nervosa patients continue to be hyper-concerned with weight and body shape after recovery. A large percent of recovered women also continue to resemble ill women in their indications of alcohol or substance dependence, depression, OCD, or GAD. Patients with bulimia nervosa were seen to have decreased levels of cholecystokinin. Cholecystokinin is known to be associated with satiation in both humans and animals. Decreased levels of the hormone would decrease satiation in patients with bulimia nervosa and inhibit their ability to digest fats and lipids. This lowered ability could aid in the maintenance of the disorder. The effects of these abnormalities may be improved using tricyclic antidepressants that affect serotonin levels. An adjustment of serotonin levels may compensate for the decreased satiation and digestion. Controlled clinical trials investigating the treatment of bulimia nervosa are low in number and have lacked depth in analysis. Trials so far have shown an effectiveness rate of 60 to 70% using cognitive behavioral therapy, CBT, with a 30 to 50% remission rate. Antidepressants have also been used in the treatment of bulimia nervosa and pose promising results. However, like drug treatment in several anxiety disorders, the effectiveness of these drugs tapers off as use continues and may not serve much benefit in the long term. Shapiro, Berkman, Brownlee, and Associates recently performed a study reviewing 47 experiments that examined the efficacy of various treatments for bulimia. They found that fluoxetine, an SSRI given in 60 mg per day doses, was the most effective in reducing the binging and purging symptoms of bulimia. Proferamine, a MAOI, also showed decreased purging activity. Researchers further found that CBT is the most effective behavioral therapy. Interpersonal therapy also seemed to be successful in treatment. Although the symptoms of bulimia may subside after treatment, it is likely that the comorbid disorders will continue to need attention. CBT is so largely successful in these two areas, but treatment is also more heavily dependent on a desire from the patients to get better. With this, it's important for society to realize that eating disorders are psychological disorders like any other. People suffering from bulimia deserve the respect and care that those with disorders like OCD, schizophrenia, and depression have received, and should not be looked down upon. People have begun to realize the dangers of the sociocultural model of the past few decades and are making efforts to emphasize the beauty of a full figure. But even that distinction, again, separates a thin body from a real body. This ideal is so ingrained into society, but hopefully with acceptance and awareness, eating disorders stemming from a desire to fit into a cultural mold will be extinguished.
There's so much they hold.